This is one that is obviously important to me, but I think it's one that needs to be important to all of you within the healthcare setting and so forth. This is an issue that unfortunately creeps into your hospital. And to quote Dr. Lewis, if you don't have a fungal problem, you're probably not looking. So with that, our next talk is going to be overcoming challenges in the management of invasive fungal infections. Our speaker with us today is not only a very close friend, a mentor, and someone who I consider very important in the arena of infectious diseases. It's Dr. Jim Lewis. He's the ID Clinical Pharmacy Coordinator at Oregon Health and Sciences University, so obviously he gets the award for the longest travel to get out here. He's with the Department of Pharmacy and Infectious Diseases in Portland, Oregon. He received both his Bachelor of Science in Pharmacy as well as his Doctorate in Pharmacy from Washington State University. Then went on to do a pharmacy practice residency at Southwestern Washington Medical Center in Vancouver, Washington, an ID pharmacotherapy specialty residency at the University of Texas Health Sciences Center at San Antonio and the South Texas Veterans Affairs Medical Center. Most of you are well aware he's significantly published in the ID literature. And with that, Dr. Lewis and fungal infections.
All right. Well, fortunately, I am not the only thing standing between you and lunch. You know that is like the worst spot ever, so I'm very happy to hear that there's someone else in that spot this morning. But we're going to talk about fungal infections. There's my disclosures up there on the slide for you to take a quick look at. Promise to behave myself. And the learning objectives. And you are all an extremely intelligent group of people. You made it through pharmacy school. Therefore, I am not going to stand up here and read you a bunch of learning objectives, but take a little bit of a look at them there so you can kind of see what direction we're taking. So let's start with this, okay? Let's go patient case here. And this probably is going to look very similar to a lot of patients that you see day in and day out in your institution. And this is a 62-year-old female with a history of diverticulitis who comes in because she's possibly perforated her bowel. Now, she is receiving vancomycin and piperacillin tazobactam. I can tell you that at Oregon Health and Sciences University, as well as at the University of Texas for years, this was what you got as we were wheeling you into the hospital, okay? It's like, you're going to get vanc and pip-tazo while you're here. Welcome. Now, some of you are sitting out there going, we don't do that. We don't do that. Yeah, you do. You just use vanc cefepime or vanc. If you're really evil, you use vanc miro, right? And the evil people in the room, hang your head in shame. Okay, vanc miro, evil stuff. But you're going to get some of the broad spectrum intra-abdominal coverage type stuff here. And she's doing great. Okay, she looks great through hospital day 5. You go home that evening feeling well about how this woman is doing. But you come in the next morning and her fevers have all of a sudden kind of jumped back up and her white count is starting to move back up. Also, so they take her back for further imaging, and they discover that there is a new fluid collection that has developed in her abdomen in proximity to where some of the surgical procedures were done. What should you be thinking about at this point? And I will tell you, since we're talking about antifungals, this question shouldn't be too hard. Okay, so really what grows through vancomycin and pip-tazo? What grows through vancomycin cefepime metro? What grows through vancomyropenem? Candida. Okay, and when you look at cases like this, one of the things I want you leaving this room with is a heightened sense of awareness and really putting this pathogen on your radar sooner than you might be right now. Because when you look at this, and this is now a study that's 4 years old that came out of the New England Journal of Medicine a couple years ago from a little group that you might have heard of called the CDC, okay? And what they did was they went to U.S. hospitals and they said, on this day, we want you to tell us of all the healthcare-associated infections that you're dealing with, we want you to tell us what organism is causing it. Now, first and foremost, I want you to notice the top line, Clostridium difficile. Guys, if you need an excuse to tighten up your antibiotic stewardship programs, that's it. The number one cause of healthcare-associated infections in the United States in this paper on that day was C. diff. That's us doing bad things to our patients with our drugs. But that's a different talk for a different day. What I want you to do is go to the bottom of this slide and notice the font in orange. Notice that sitting down there at the bottom of this is Candida species. Go all the way over to the far right bottom corner of this slide. And what you will notice is that it is the number one cause of healthcare-associated bloodstream infections in U.S. hospitals on this day. So for those of you who are even thinking, we don't see Candida, I am still amazed at, one, the number of people who say that incorrectly and say, we don't see Canada. That's a country. It's north, okay? We are not talking about killing the Canadians. Okay, that's not what we're doing here today. They get really grumpy and they come after you with hockey sticks, okay, when you say stuff like that. We are talking about killing Candida, so please be sure to put all of your D's in the right places when we're talking about this. But I am amazed at the number of people that tell me that they don't see this in their institution. If you don't see this in your institution, and Dr. Fugit stole my thunder by taking my jokes. I hate it when he does that. But if you don't see this in your institution, you're just not looking, okay? And that's the number one way to not find something, is to not look for it. Because, again, consistently what you see, this day it was number one, but consistently what you see is that this is the number 3 or 4 cause of bloodstream infections in U.S. hospitals. So really this is a common organism and a common condition. And again, you see that on this slide. But this is also the most common fungal pathogen that we see in U.S. hospitals, and it's got an attributable mortality of roughly 15%. However, okay, you've got an attributable of 15, but the crude mortality is 40%. Okay, think about that for a minute. That means that every time somebody develops candidemia, there is a 4 in 10 chance that they don't leave your hospital except through celestial discharge, okay, which is always the wrong way to have your patients leave the hospital. Now, that being said, that is a marker of severity of illness for who gets invasive candidiasis, but I've already shown you that it's common. I've now shown you that it's lethal, and it's got at least a 15% attributable mortality. So even worse, best case scenario, 1.5 out of 10 people die because of this disease state. Also, how many of your hospital administrators are excited, yippee-ki-yay, grins and giggles, about adding 10 days length of stay to everybody? Anybody? Right? My hospital right now, we are basically doing everything we can to get people out the door because we're perpetually full and perpetually on divert. If I tell our hospital administrators I'm going to tack on length of stay, they're going to lop my head off. Okay, and so, I think that there are multiple things here. You see that this is common. You see that this is lethal. And you see that it is expensive to the U.S. healthcare institution and to the patients who are unfortunate enough to develop this disease. Also, what has happened in the last couple of years is that we've seen the IDSA update their guidelines to reflect some significant changes in the way that we manage this disease state. And from a pharmacist standpoint, there is one massive change lurking in here that we're going to talk about as we move forward. But again, we've kind of already started with the case, looking at what some of the risk factors are for this disease state. But this list right here is taken straight from the guidelines and really needs to be something that you're familiar with if you're routinely taking care of hospitalized patients. When you go through those risk factors, does that look like everybody in your institution, right? And that is why this is common, is because central venous catheters, colonization, severity of illness, broad-spectrum antibiotics, recent surgery, pancreatitis, dialysis, TPN, and steroids. Do we do that stuff just occasionally in U.S. healthcare in 2018? Right? So you see that a lot of the risk factors for this disease state are very common. But what I really want you locking in on is the bottom of this slide. The bottom of this slide has a particularly high-risk subset of patients that if you encounter these people, you really need to be thinking this is a setup for invasive candidiasis. And we're to the point now at both Oregon and previously when I was at Texas, where you could kind of look at the patients and be like, you're an extremely high-risk individual. And that would be the vast majority of where we saw Candidemia develop. And these recurrent GI perforations with anastomotic leaks or necrotizing pancreatitis that keep having to go back to the OR, these are the types of folks that should be setting off major alarm bells in your head when you see them. And again, we've talked a little bit about why this disease state is important, but we also need to think about this very similarly to bacterial infections. Would anyone in this audience be satisfied with someone who said, you know, this patient's looking a little sursy? Don't you love that as an adjective? Have you heard that from your medical team? Well, they're sursy. They look sursy. I don't even know exactly what that means, but okay. But if you have someone who looks like they're borderline septic, would any of you be happy with the answer, well, you know, I think we'll sit and wait on antibiotic therapy and we'll come back in the morning and see how they're doing, right? Anybody going to sign on for that? You got Pseudomonas maybe Pseudomonas in the blood, maybe Pseudomonas in their lung or MRSA, and it's like, you know, we'll just kind of watch them. No, right? We know that delays in effective antibiotic therapy basically increase mortality at a rate of 7% per hour, okay? So we run around. We have CMS forming sepsis bundles to where we have to have antibiotics on board, preferably within 30 minutes. We have code sepsis teams that run through our hospital and make sure we start antibacterials. Why do we not give this organism the same level of respect? Here is one of at least 4 or 5 studies that shows you that delays in effective antifungal therapy increases mortality upwards of 30 to 35%. This study particularly shows that if you're worried about somebody and you draw a blood culture, and that blood culture later becomes positive for Candida, if you started effective antifungal therapy within 12 hours of that blood culture being drawn, your mortality is only 10%. But if you wait until that blood culture goes positive, usually more than 48 hours after it was drawn, your mortality is now roughly 40%. Okay, so again, we see not only in the bacterial world, but also in the fungal world that delays in appropriate therapy kill patients. The other thing, too, that's important is that the epidemiology of this disease has changed markedly over the last 30 years. If we did this talk 30 years ago, it would be Candida albicans, Candida albicans, Candida albicans, and more Candida albicans. But what has changed is that Candida glabrata has become much more of an issue. And Candida glabrata now represents roughly a third of bloodstream isolates in U.S. hospitals. Okay? And there is some epidemiologic difference between centers. If you work in an institution that ends in cancer center, such as Memorial Sloan Kettering Cancer Center or MD Anderson Cancer Center, if your hospital's name ends in cancer center, you're a lot more likely to see glabrata, but you're also a lot more likely to see Krusei. Okay, so there are certainly differences in the epidemiology between the institutions, but nationally we know that about a third of bloodstream isolates are now due to glabrata. And the reason that that's significant is on this slide, right? When you look at Candida glabrata, you notice that all of a sudden you have a susceptibility problem. And that susceptibility problem is for all of your azoles, okay? One of the things that I hear that makes the hair on the back of my neck stand up is, I'm worried about fluconazole-resistant glabrata. I'm very concerned. I'm terrified of fluconazole-resistant glabrata. Wrong. Okay? Those are words that should not come out of someone's mouth who's taking care of a patient, because is this a fluconazole problem or is this an azole problem? Or as the Europeans call it, and my wife is known to call me, an azole problem. Okay? My wife, though, is not referring to antifungals when she calls me an azole. Okay? But this is an azole problem. The Candida glabrata doesn't care if you spent $2 on fluconazole or if you spent $400 on IV posaconazole. Basically, all of them are going to get effluxed exactly the same, which is why you'll notice that all of the azoles, and ISA is not up there, but ISA has the exact same problem. Okay, so really what you need to be recognizing is that the azole challenges with glabrata are not just for fluconazole, but are class-wide. And that's really, again, one of the strengths of the echinocandins. Because when you look at this, you see, similar to what we've been saying, that orange part of the pie sitting there at the bottom, this, guys, is all glabrata. Okay, and so basically you've got a third Candida albicans and a third Candida glabrata. And this is data from CDC ongoing surveillance that they've been doing in Baltimore and Atlanta for basically the last 20 years. So we've seen this epidemiologic shift, and this is significant for us because it markedly impacts what agents we use and recommend in patients who develop candidemia. So let's come back to our case for a minute. All right, we're now to the point where we've had these blood cultures drawn, and look at this. On hospital day 5, the blood cultures that were drawn on hospital day 5 are now positive for yeast. Okay, now you're lucky in that you don't live in Cryptococcus gaddii country like we do in Oregon. In Oregon, if I see yeast on a blood culture, my first question is this crypto or is this Candida? The issue is not as much with some of the endemic fungi that would be confusing on your stains, and so the likelihood is that this is going to be Candida. So the question you should be asking is, at this point, what drug therapy should we be going with? And that's one of the major changes in the 2016 IDSA guidelines, because these quotes are taken pretty much straight from the guidelines. And notice now, bullet 1, notice that echinocandin therapy is now preferred for everyone with candidemia, at least for the first couple of days while you get determination of what the organism is and hopefully what the susceptibility is of that organism. Notice that fluconazole is still an acceptable alternative and is encouraged for step down in clinically stable patients who do not have an organism that is resistant to fluconazole and have not had prior azole therapy. Usually within about the last 3 to 6 months is the window that we think about. But I also want to draw your attention to something very important. The drug name in bullet 1. What is the drug name in bullet 1? Well, that, guys, is whatever-a-fungin. Okay? Whatever-a-fungin is basically means I don't care what echinocandin you use. Okay? Whichever one is on your formulary, knock yourself out. Really, the guidelines do not distinguish between the 3 echinocandins that are currently clinically available, and clinically there are not significant differences between this class. So really, whatever echinocandin your institution wants you using from a formulary standpoint is perfectly reasonable to use in these patients. But again, at the end of the day, where do these guidelines come from? And again, you see the IDSA as well as the European Infectious Disease Society both saying the same thing, that now echinocandins are the preferred therapy for invasive candidiasis. Where's this data coming from? Well, it comes from a paper that was published now 6 years ago in Clinical Infectious Diseases that was basically a patient-level drill down on 7 phase 3 randomized registration studies that were done for invasive candidiasis. You had data for all 3 drug classes. You had your azoles, you had your amphotericin B products, and you also had your echinocandins. So you had robust data that basically was able to be drilled down to the patient level by David Andes and his group. And there were almost 2,000 patients across these 7 trials that were included in basically this kind of high-end meta-analysis that they did. A couple of very interesting things emerged from this literature. One, the overall mortality rate is still 1/3. Guys, these are our newest drugs. The echinocandins, the new generation azoles, the lipid formulations of amphotericin B, and we still have a 30% mortality rate in these patients. That's not acceptable. And so we need to be doing something, and we need to be doing a better job to try and get that mortality rate down. The treatment success stuck at about 70% for all of these agents. What predicted bad outcomes in your patients or in the patients in this study? 1, don't get old. Getting old is dangerous, right? Think of any study where getting old was associated with a lower mortality risk, right? I mean, getting old is dangerous stuff, and you see that again in this study. Other thing, don't get sick. If you have a high Apache 2 score, you may die, right? And again, we see that in this study. Also, don't let these oncology people immunosuppress you. They're a bunch of whack bags. All their drugs end in MAB. You can't even pronounce their drugs. You don't know what they're doing to you. And this CAR T therapy, I mean, come on. Yeah, and again, anyway, I'm not going to go on my P&T rant about cancer drugs. And I don't understand this point, infection with Candida tropicalis popped out. And this is the second time or third time we've seen this, but I don't really understand it because tropicalis doesn't look more virulent than albicans. And so it's something that I've seen in the data before, but I don't really understand. Maybe it's something about patients that get tropicalis, but there's really no signal there that they were markedly different. So I don't understand why that's there, but the data is the data. What could you do to improve the likelihood that your patient would have a successful clinical outcome? One, pull the line. Now, some of you are sitting there, right, and you're looking at me and you're going, Jim, we're pharmacists. We don't do line management. True, but you're part of a multidisciplinary team and you can pipe up and say, how long's that line been in? Well, you know the number one reason people get candidemic? Lines. And getting the line out, 50% reduction in mortality. That will get people's attention. So let's say you say all that. Okay, you say all that, and your team's looking at you like this. Right? The blank face team, the coffee hasn't kicked in yet. Some of you are giving me that look right now, so I know it well. Basically what you do at that point, let me demonstrate. Okay, this is called pharmacist line removal technique. Okay? You act as though you're walking towards the door and you trip. Oh no! And you accidentally grab their central line as you're tripping, right? You just saved your patient. That is pharmacist level care right there. I mean, we should be billing for that type of effort, right? I mean, there you go. So tell me you can't remove lines. I'm very proud of you all. Now, don't do that. I had one person actually say to me one time, that sounds dangerous. Dude, it was a joke, right? Oh my gosh. You have separate medical issues beyond central lines if you didn't figure out that was a joke, okay? Now, but look at the second set here. The second set. Treatment with an Echinocandin reduced the risk of death by almost a third, or the risk of a bad outcome by almost a third. Okay, now remember too, this was compared to the new generation azoles and Amphotericin B products. Okay, so this is really where the recommendation came from in both the European guidelines and the U.S. guidelines that made Echinocandin therapy now preferred for upfront. Okay. No matter how you cut the data, this was a robust finding. But there are a couple of points here, okay? One, at no point does this say in this document or in the European document that if a patient is clinically stable, you know what's going on, that you can't transition them to Fluconazole. And I think that that's really one of our big pushes from an antifungal stewardship standpoint, is to get them off Echinocandins once we've stabilized them and we know what's going on, down to our Fluconazole that is our kind of preferred agent. But up front, Candida in the blood, high risk of Candida in the blood. The guidelines are very clear now that Echinocandin is the preferred agent, and it doesn't matter which one. Now, this bugs the living bejesus out of me. This is kind of the bane of my existence wrapped into one nice, tidy little package. And I would strongly encourage you to read this. It's an evidence synopsis published in JAMA last year. And one of the major challenges that we continue to have in the management of Candida infections is that our diagnostics suck. Blood cultures turn positive late. They only turn positive in roughly 50 to 70% of patients with invasive candidiasis. And so we've been doing this kind of risk-based approach to giving people early antifungal therapy, but in study after study after study, it doesn't work. It always trends in the right direction. But what this says is, even with our best prediction rules, we're not terribly good at figuring out who the right patients are to prophylax, or not necessarily prophylax. I would tend to call that actually more early empiric therapy in high-risk patients. We're not good at it. And so this is an area where we really need improved diagnostics, and I'm hopeful that over the next 5 to 10 years, years, we'll see improvements in diagnostics to allow us to better target these people with effective therapy sooner. The other thing that's buried in the guidelines is that all of your labs now, and again, this is not Jim made it up. This is not the Journal of Pharmacy Wishes, okay? This is what the Infectious Disease Society of America is saying should be standard of care in your institution. All bloodstream Candida isolates now should be getting susceptibility testing at least for Fluconazole. At least for Fluconazole. And notice that's not some, that's not occasional, that is all. Now, before your lab starts hyperventilating, reassure them that you're not talking about Candida from urine cultures, okay? Most academic medical centers see at most 50 to 70 Candida bloodstream isolates a year. Okay, we don't tend to see in most centers a lot more than that. So you're not talking about a huge workload. But because of the emergence of Candida glabrata with varied susceptibilities and other kind of concerning trends with regards to antifungal susceptibility out there, bloodstream isolates should be at least getting tested for Fluconazole, and preferentially Fluconazole and Echinocandin. But most labs are not capable of doing Echinocandin susceptibilities at this point in time. When should you be thinking about an Echinocandin-resistant organism? When a patient has been on an Echinocandin for 4 to 5 days or has been on it previously, and now they have a new Candida isolate. Okay, I think a lot of us have been guilty for a long time of assuming the Echinocandin will fix it. There's no resistance problem here. Have we ever gotten away with that? We have never, ever gotten away with our new drug is going to whoop you, right, in the antibacterial or antifungal space. The bugs always mutate. That's why ID's cool. But, right, you've never seen cholesterol mutate, right? You ever driven by a donut shop and went, I ain't going in there. That's where the Lipitor-resistant cholesterol lives, right? You're not going to do that, right? But the bugs don't stop, right? And we've seen this with echinocandins too. So don't go decerebrate on me. And remember that, even if you've seen, or especially if you've seen recent echinocandin therapy, that there is the potential for resistance to emerge. So let's come back to our case again. What empiric therapy, notice she's grown Candida albicans from her blood. What empiric therapy should she have received, or should she receive? Echinocandin. In 2018, the answer is Echinocandin. Now, can you step her down to Fluconazole once she's stable, once everything is good? Absolutely you can. Is there any magic number to when that needs to occur? No. Okay? She needs to not fail the OO test. For those of you not familiar with the OO test, it's when you walk into the room and the patient's so sick, you go, ooh, right? That is a negative OO test. If you walk in there, ooh, you're sick, right? That's not when you want to be transitioning back to Fluconazole. But if you walk in and the patient's like, this cherry jello is the bomb. Can I go home tomorrow? That's probably a reasonable person to transition to Fluconazole, right? So, again, keep brain engaged and think about this from a clinical standpoint. The other issue you've got is Candida auris. This is going to bear watching. Candida auris has emerged globally in separate locations all at once. Nobody's really sure why. The major problem with Candida auris is that at least the ones coming out of India and China are basically resistant to azoles, echinocandins, and ampho. What's that leave you? Yeah, a whole lot of nothing, right? We've been very lucky in the U.S. thus far that the majority of ours have retained susceptibility to echinocandins. But again, Candida auris is one of these organisms that the CDC wants to hear about, that your labs should be looking for, and that you should be aware of. This is kind of, I think, the next bug from a fungal standpoint that there is a lot of concern about. And if you're interested in this, as you should be, take a look at the CDC's website for where isolates have been seen. Again, New York is proving that they're unable to wash their hands. We had the KPC problem there. We've now got Candida auris there. New York, come on, get with the times, baby. That Purell hand gel on the wall, come on. I mean, boom, boom, all good, right? So, but again, we're seeing in the Northeast Candida auris kind of becoming the challenge. So to wrap up the Candida section here before we move to mold real quick, The thing for you to leave the room with, echinocandins are first-line therapy in 2018. Anyone who is candidemic should receive at least 1 or 2 days of echinocandin therapy and then can be rapidly transitioned to fluconazole based off susceptibility results. Also remember that, especially with glabrata, none of the newer azoles offer you anything over fluconazole, okay? So if you've got a fluconazole-resistant glabrata, don't think that spending a bunch of money on Posa, for example, is going to do you any good. The epidemiology nationally appears fairly stable, but you need to know what's going on in your institution. You would not be satisfied, or you shouldn't be satisfied, without an antibiogram in your institution. Why do you not have a similar understanding of what's going on with Candida in your institution, okay? Something to think about. And also, Candida glabrata, we're seeing increasing reports in some centers of echinocandin resistance. At last I heard, Duke was reporting that 15% of their Candida glabrata isolates were now echinocandin resistant. We've seen some echinocandin resistance. This is, something that needs to be on your radar. And then also pay attention to what's going on nationally with Candida auris. So let's spend the last few minutes talking specifically about Aspergillus and the azoles. We not only got new Candida guidelines in 2016, but we got new Aspergillus guidelines as well. The changes in this document weren't quite as dramatic. If I walk up behind you in the hall out during break and I say Aspergillus, you have 3 seconds to get the word Voriconazole out of your mouth. Okay? Now, if you were my ID pharmacy resident, you'd have 1 second. So I'm being extremely generous here, right? Aspergillus, Voriconazole. And really, the alternatives at this point in the guideline are Isavuconazole and lipid formulations of Amphotericin B. Now, that being said, the new European update has Isavuconazole and Voriconazole on level footing. The reason the IDSA guidelines did not put ISA and Vori on level footing, and I'll show you that data as we move forward, is that the ISA data wasn't done and in full peer-reviewed form when these guidelines wrapped writing. They only had the abstract available, and so they weren't comfortable making a recommendation based off data that they hadn't seen in its entirety yet. But the Europeans this year now have placed Vori and ISA on level footing for invasive aspergillosis. Also note that echinocandins are not recommended for primary therapy. So while they're the bomb for invasive candidiasis, they're well down the ladder when it comes to invasive aspergillosis. So you've got a 53-year-old dude with AML, normal cytogenetics, admitted for induction chemotherapy, and planning to be followed up and undergo a stem cell transplant. What fungal infections do you need to consider? Let me tell you right now, guys. AML, your Aspergillus red flag or red light should just start flashing. This is the bug that we worry about. This is the bug that kills these patients. This is a major challenge in this population. So, Voriconazole, we've already talked about, remains the frontline therapy for invasive aspergillosis in 2018. It's now generic. So insurance companies are pushing it super hard, and the prices are considerably lower than either ISA or Posa. So that from that standpoint, it's a little bit cheaper, but it's still not cheap for our patients. We still have a lot of issues getting this funded for folks. The thing you need to remember about Vori is that it's gold standard for invasive aspergillosis, but it has no mucor activity. No, none, zip, zero, zilch. The other thing, too, is these broad-spectrum azoles, of them, Voriconazole probably has the most complicated drug interactions, so it's great job security for everyone in this room, okay? Because let me tell you, the providers cannot keep track of these drug interactions. The downside to this drug is, first and foremost, if you get the levels too high, patients will tell you that Chewbacca is on the ceiling. Literally, report out of NIH several years ago, they walk into the patient's room and the patient's like, yeah. Got to tell you something, doc. Chewbacca's on the ceiling. I know Chewbacca's not on the ceiling, but Chewbacca's on the ceiling. Hallucinations with this stuff when Voriconazole concentrations get high are substantial. We had a gentleman in Texas we walked in to see one morning. He's like, the art at the foot of the bed is amazing. And guys, this was a county hospital in San Antonio, Texas. We did not do art at the foot of the bed, okay? He's like, the art at the foot of the bed is amazing. We're like, uh-oh. And he's like, And I love how you change it in the middle of the night while I'm asleep every night so that there's something new there when I wake up. And he's like, you're not going to charge me for that, are you? We're like, dude, we're not going to charge you for we're all thinking, we're not going to charge you for the hallucinations that you're having, that there's art there. His Vori level was 9. It shouldn't be higher than 5.5. Okay, so the individual patient pharmacokinetic variability on this drug makes therapeutic drug monitoring a must for Voriconazole. If you're too high, you see Chewbacca. If you're too low, Aspergillus grows. And the patient variability with Voriconazole is massive. It is a difficult drug to play with. The other thing, too, and this is buried mostly in the dermatologic literature, but we're becoming increasingly aware that skin cancer risks go up with patients on long-term Voriconazole. Also, we've kind of talked about the hallucinations already, but you've got to watch LFTs in these people. LFTs on Voriconazole, especially at higher concentrations, tend to elevate in a bit of a hurry. Posaconazole at this point in time is not indicated for the treatment of invasive aspergillosis. It's only indicated for prophylaxis in high-risk groups. Okay, namely your AML population, your AML-type patients who have graft versus host disease, those folks that are at very high risk for developing invasive aspergillosis. And it's actually been shown to be associated with a mortality benefit in that group. Now, that being said, the liquid formulation of this compound needs to be taken out back and shot. Okay? The package insert now, per the FDA, states that the tablets and the intravenous formulations are preferred. Guys, the FDA does not make comments like that. The FDA does not make comments that one formulation is preferred over another, which tells you that the liquid sucks. Okay? The liquid really sucks if you're getting the FDA to say that. The other thing from this audience's perspective is the dosing. The dosing is completely different with the liquid as compared to the tablets and the IV. There have been cases of this dose getting mixed up. There have been warning letters sent from the FDA and the EMA. You need to be aware that the liquid and the tablets and the IV are dosed very differently when it comes to Posaconazole, so be careful with this one. We've talked a little bit already about the oral suspension. You should not be using that. And if you are using it, it needs to be in a situation where you do not have acid suppression, because if there's acid suppression, you don't absorb this stuff. The good news is the tablets are not acid dependent, and so PPIs are not nearly as big of a deal here. Let's talk a little bit about, yes, that's really the name. Isavuconazole. But ISA, okay? ISA is indicated for the treatment of invasive aspergillosis as well as the treatment of mucor. That being said, realize that the mucor indication is based off of around 35 patients and a historical control against Ampho. I think most people would still start with lipid formulations of Amphotericin B for your mucor or your zygomycetes at this point in time. However, head-to-head against Voriconazole for invasive aspergillosis, ISA looked the same. The outcomes were basically the same. But what was different was that really ISA looked a little bit better tolerated. Okay, so ISA looked a little bit better tolerated, and it has less PK variability associated with it than Vori does. So I think that ISA at this point in time is probably an easier drug to use clinically, but unfortunately getting it paid for is very difficult. Okay, again, third-party payers really want you using Vori because it's generic and it's cheaper, and this has been a major challenge for us to get our hands on at Oregon for patients, just because everybody wants you to go through Vori first. But the adverse drug events on ISA and the PK of ISA are definitely a little bit cleaner than what we've seen from Voriconazole. So let's come back to our patient case here. Okay, he basically comes in and he gets his stem cell transplant, and his neutrophil recovers he undergoes induction, and his neutrophils recover on day 26. He's discharged on day 29. He gets readmitted to undergo an allo transplant from his brother, which was successful, and then he's discharged home. However, okay, he gets readmitted with pleuritic chest pain, dry cough, and a new centimeter-sized nodule on his chest CT. Guys, that is code for invasive aspergillosis. Everything about that guy is classic for invasive aspergillosis. And I will tell you that one of the biggest controversies we're going to have in this field over the next decade is this study right here. This was a paper that was published in Annals of Internal Medicine in 2015 from Kieran Marr. And what this is Voriconazole alone versus Voriconazole plus an Echinocandin, in this case Anidulafungin. And on the y-axis on the left of the slide is survival. So you want to be higher up, right? The combination is the dark blue line that looks a little bit better than the monotherapy on the Kaplan-Meier. The p-value for this was 0.08. Okay? To complicate things further, the reason for failure in the combination therapy arm was lost to follow-up. The reason for failure in the majority of the monotherapy patients was death. Would you rather be lost to follow-up or dead? Right? So because of this, a lot of experts in the field now have gone to one of the new generation azoles, usually Vori, plus an Echinocandin as primary therapy for invasive aspergillosis. But the guidelines don't recommend this. And the reason that the guidelines don't recommend it is they say, hey, the p-value was 0.08. This is a negative study. You did not make your primary endpoint. To which a lot of other people say, hey, the thing was underpowered, and look at the reasons for failure. They're very different. So this study. Bring the popcorn, bring the Diet Coke, sit in the back of the room, preferably in a corner, because the fungal guys take their studies very seriously. They're going to go all WWE smackdown on each other over this for about the next decade, right? So they will be insulting each other's mothers. It will be outstanding TV to watch. But remember, keep your back to the wall so nobody hits you with a chair from behind, okay? And if you're just bored at a meeting, yell combination therapy for aspergillosis in a room full of ID docs and just watch mayhem break out. All right, toxicity and monitoring. We've talked about how Vori's tricky. Therapeutic drug monitoring for Vori is required. For ISA, we don't know. For Posa, I would still probably be doing it even with the new tablets and the IV formulations, just because there is about 10% of patients who still aren't getting to that therapeutic range, even with the new tablet and IV formulations. And drug interactions, guys, all of these azoles, remember the mechanism of action is Lanosterol demethylase inhibition, which is a P450 mediated enzyme in fungi. You cannot get away from the drug interactions with these compounds, and you can hurt people with the drug interactions with these compounds. So this is really an area that we need to be on our A game. So in 2018, you've got 3 advanced generation azoles. You've got Vori, you've got Posa, and you've got ISA. The indications are different, but I think for Aspergillus, they're all kind of about the same as long as you dose them right. For prevention, really, Posa has the best data at this point, but again, I think depending on the patient and the setting, you can really use any of the 3, even though the indications are markedly different. All of them, especially now with the new formulations of Posa, are well absorbed, are pretty well tolerated. And the interchangeability, I think the major thing to remember is that Vori has no zygomycete activity. That is a huge difference as compared to either ISA or Posa. Thank you very much, guys.